Med-Surg students, now I'm going to take you through exams 2 Quizlet on other endocrine disorders. I did diabetes because that's a beast in another video. So first we're going to talk about agromedley. So we're going to talk about pituitary problems. Okay, so you're going to need to know about SIADH, but I'm going to do that in another one. But just remember, deficiency in ADH causes diabetes insipidus, which has nothing to do with diabetes mellitus, okay? And then if you have too much SIADH, that's going to result in syndrome of inappropriate ADH secretion. And this occurs, remember we did TBI, so it can occur in head injuries, brain tumors, for drugs, the lung cancer. There's all kinds of reasons people can get this, but you have to know how to, figure it out. Okay, so with DI, they're going to have copious amounts of dilute urine secretion. So the specific gravity of the urine before DI is treated is going to be very low. Okay, it's going to be close to water. Okay, so usually it's like 1.005. It may even be lower than that. Now we're going to talk about growth hormone because that's produced in the anterior pituitary gland. And it's going to result, like, if there's an overproduction of GH in children, so this is before their bones have that epithelial, I forget what the name is, but when children are growing, their bones are still growing. Now, when those plates are healed, the bone doesn't grow anymore, so they would get acromegaly as an adult, but as a child, because the bones are still growing, if they have an overproduction of growth hormone, they're going to have giantism. And it's important you know that, like, the difference between that. Acromegaly is not going to increase height because the bones are all fused. So what you're going to see is normal height, but they'll have large features of the face. Like they have like a big forehead, and it's called like a bossing forehead. It kind of looks like a caveman forehead. Okay, they're going to have a large tongue. They'll have gynomastica, and the bones in the hands, feet, and forehead and jaw widen. Okay, so that's how you'll tell. Oh yeah, and because their epiphyseal plates are fused, so that's why they have an enlargement. And then they're also at risk for other diseases. With your assessment, they're going to have like joint pain, arthritis. They'll have high blood pressure. They could have carpal tunnels, diabetes, and all their organs are going to be are enlarged, and they'll have field deficits, which means they'll have problems with their vision. And that's because the optic nerve is really close to the pituitary gland. Okay. And they may undergo a growth hormone suppression test to see if they have high growth hormone levels. So that one's kind of short. And you probably maybe won't even see acromegaly in your nursing practice. So now we're going to talk about adrenal disorders. I kind of find these fun. I don't know why, but I really enjoy adrenal disorders. So you have to know the hormones that are secreted from the adrenal gland, and they include norepinephrine and epinephrine, mineral corticosteroids, so aldosterone, and glucocorticoids, which is cortisol. So, a pheochromocytoma is a benign tumor of the adrenal gland. So, although it's benign, sometimes we can have benign tumors that wreak havoc in the body. What happens is this benign tumor secretes catecholamines. And the catecholamines are your epinephrine and norepinephrine. And I'm sure you probably figured out by now, if somebody is secreting these enzymes, they're going to have extreme hypertension. They're going to have extreme diaphoresis. They're going to have extreme headaches and palpitations with tachycardia, and they'll be pale. So you kind of have to kind of visualize that. They go into an extreme state, and this can be deadly. Their blood pressures can get extremely high. So the treatment is they're going to get alpha agonists and beta blockers, okay, and surgery. So they'll take out the adrenal gland. And so Addison's disease can occur after that. So because that occurs if the adrenal gland can't produce enough of the hormones. So the hormones that are deficient in Addison's disease are cortisol, aldosterone, and testosterone. So you can remember that they're going to be low in sugar, salt, and sex. Okay, cortisol is the stress hormone, and the cortisol's function is to help us with the stress response, and it increases our blood glucose. So it helps us counteract the inflammatory response and helps with metabolism. So if my patient doesn't have this, like in Addison's disease, they're not going to be able to handle stress, and they can go into what's called an adrenal crisis, and they're going to need steroids for that. So to keep that in mind. So aldosterone, what that normally does, it helps us retain sodium in water and helps us conserve water and helps us excrete potassium. So if my patient has Addison's disease and they have low aldosterone, they're going to have increased potassium, okay? And they will be hypotensive because they're not holding on to sodium. And then how you can remember the signs and symptoms of Addison's disease is with the mnemonic steroid, okay, because you're going to have to know. So S stands for sugar and sodium low. T stands for tired and muscle weakness, and that's due to the hypoglycemia. E stands for electrolyte imbalance, so they're going to have a high potassium and a high calcium. R stands for reproductive change, so that's the sexual problems that they could have. O stands for low blood pressure, so they're going to be orthostatic, and remember that's a safety concern. I stands for increased pigmentation of the skin. They look bronzed or tan. And D stands for diarrhea, nausea, and depression. So the labs you're going to see in somebody with Addison's is the high potassium, low sodium, high WBC, low glucose, and blood, saliva, cortisol is going to be decreased, and the BUN and creatinine will be increased. So if somebody has deficiency in glucocorticoid, like people with Addison's, they're going to be prone to hypoglycemia. So remember your B stressed to look out for those signs and symptoms. The treatment is going to be, they're going to have to go on chronic steroid treatment. And if they go through periods of increased stress, they need to let their provider know so that they can get their steroids increased, because they can go into adrenal crisis due to having, increased stress. So the others, if they have if you're caring for them in the hospital, you're going to monitor hypotension, orthostatic hypotension especially, make sure they're safe. And you're going to have to replace fluids and monitor for hyperkalemia and know your signs and symptoms of hyperkalemia, right? That's your muscle weakness, your respiratory distress, your EKG changes, and hyperreflexia. All right. And then the treatment of hyperkalemia, you can remember with kind. So you're going to have to know this for exam 2 and 3. So this is Kayexalate, which is given orally or by enema, insulin with dextrose, sodium bicarb, and diuretics. Now, this is to lower the potassium. If you're in an emergency, like you need to get it down fast, the first line of treatment is going to be your insulin and dextrose, because that happens immediately. Like if somebody has DKA and a high potassium, you're going to give the insulin with the dextrose. All right, review your Be Tired. I went over that in another video. And then you should know the side effects of corticosteroids. And you can remember the six S's, because they're going to be sick, so easier to get sick if you're on steroids. You're going to be able to catch infections easier, so tell them to avoid crowds. They're going to be sad because it causes depression. Steroids can also cause psychosis. Sex, they'll have a decreased sex drive. Salt, steroids make them retain all the salt and cause weight gain, but it can also cause hypertension, because when we do Cushing's disease, they hold on to sodium and water, and that's what leads to hypertension and heart failure. Okay. Sugar, it raises blood sugar. And if somebody's on chronic steroids, like somebody with Addison's disease, they're going to be prone to osteoporosis. All right. So they need daily weights, high protein, high carb diet. So Addison's crisis, I have a feeling this is going to be a Proctor topic. So this happens when people get stressed out and they have Addison's disease. So they are going to need aldosterone replacement, but also glucocorticoids as well, like hydrocortisone or methylprednisolone. Okay, so that helps reverse it. And they should never, nobody should ever stop taking corticosteroids suddenly. They have to be tapered off them. And then know how to treat hypoglycemia. I talked about that in another video. So with Cushing's disease, like all these endocrine disorders, there's like, they have the opposite, right? So Cushing's disease is like the opposite of Addison's. And what you might want to do is make a table for yourself and kind of compare and contrast, or make a Venn diagram. So the signs and symptoms of Cushing's disease, you can remember the mnemonic stress U. So S stands for their skin is fragile. So like you'll use like paper tape if you need to, tape anything to the skin. And sleep disturbances, like they can have insomnia. T stands for truncal obesity. They have teeny tiny arms and legs. So like the legs and arms are skinny, but the abdomen's obese. Okay, they'll have tachycardia. They're going to have R, rounded face. It's called moon face. E stands for ecchymosis, elevated blood sugar, elevated weight, and edema, because they hold on to sodium and water. Okay, S stands for striae in the extremities in the abdomen. So they're going to have purplish striae on the abdomen. I would Google a picture to see what it looks like so you can visualize it in an exam. S stands for the sugar is going to be extremely high. E stands for excessive body hair, especially in women. So they may have to shave, like a man does. Okay, so electrolyte imbalances, like such as hypokalemia. So it's kind of the opposite of Addison's. D stands for dorso-cervical fat pad. So that's like a buffalo hump. They can suffer from depression. And U stands for they are very prone to gastric ulcers. So it's kind of like the same signs and symptoms of, when somebody's taking steroids. It's kind of the same signs and symptoms. So they're prone to hypertension and heart failure, actually, because of sodium and water retention. So review the signs and symptoms of low potassium. You can remember your sick Walt Dick to remember. And then they do a 24-hour urine to determine how much cortisol they have. And cortisol blood levels, they're going to have blood draws like 2 to 3 times, even in the middle of the night. Okay, so they're going to be woken up for that. And you should already know that anybody that is gaining weight more than 2 pounds or a gain of 3 pounds over 1 week needs to let their provider know. And they need to eat a diet high in calcium and vitamin D. Okay, so that's adrenal disorders. So the next disorder I'm going to talk about is pituitary. And we kind of already talked about this in neuro, okay? But I'm going to talk a little bit more about it. So SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. It happens for a lot of reasons: head injury, brain tumor, lung cancer, kidney disease. Certain medications can trip a patient into it. Here's all the causes. Okay, so what you need to know is the signs and symptoms. Most of the signs and symptoms of SIADH are due to low sodium because the body holds on to extra water. Okay, so they're going to have extra water, and they're not going to be voiding, so they're going to have a low urine output. The salt is going to be low, so they'll have a low sodium level. Serum osmolarity is low. Anybody with low sodium is going to be prone to seizures, and that makes me nervous because it's a safety issue. They're going to be irritable. They'll have increased weight. Anorexia with nausea and vomiting, that's a sign of hyponatremia. They'll have a decreased LOC. They could be disoriented. They will have a decreased urinary output. They will not have thirst, okay? H2O is added to the body, and they have a high specific gravity in their urine, and the head is not right, so that's confusion. The treatment is to put them on a fluid restriction. That's usually first level, right? You may have to liberalize salt in the diet, so make sure you're also putting them on INO daily weights, assessing their neurosymptoms, especially when their sodium goes below 120. I really start to get nervous. And there's drugs. They could get tolvaptan. Dimethylcycline is a antibiotic that can cause them to stop the secretion of ADH. So it actually causes the kidneys to put out more urine. Okay. So here's another. If you don't like that mnemonic, the 7 S's of SIADH, it stands for S, stopped urine and output, S, sticky and thick urine, so high specific gravity, soaked inside, so they're going to have a low serum osmolarity and low sodium, low headache, seizures, severe hypertension, and stop all fluids and eat salt. Okay, so that's basically what you're going to do. What does DI stand for? Diabetes insipidus. And usually patients get this because they lack ADH. And remember, that can happen due to head injury. That's usually the most common reason we see that. It's got nothing to do with diabetes mellitus. And remember, they're dry inside. So your goal is to always replenish those fluids because you're not going to be able to keep up. So it usually happens because of brain surgery, head trauma. Some drugs can cause it as well. The signs and symptoms, the 7 Ds include diuresis, polydipsia, so they're going to be really thirsty, dilute urine, so their specific gravity is going to be like 1.005. They'll be dry inside, hypernatremia. They'll be drinking a lot. They're going to have dry mucous membranes because they're going to get extremely dehydrated. They're going to have decreased BP, and we use desmopressin to treat it, okay? Your nursing implications, they need to be on INO. You need to measure the urine-specific gravity. They're going to need to be weighed daily. Do not restrict fluids and avoid caffeine because caffeine is a diuretic, right? So remember, like tea, cola, coffee, obviously, and fluids. Give a lot of fluids. And then the test to use to diagnose DI is the fluid deprivation test. And if you give desmopressin, so desmopressin is a vasopressor. So you have to be very careful because patients with coronary artery disease can have an MI if you give this. So you're going to look for dysrhythmias and chest pain. And then after you give desmopressin, to see if it's effective, this is what you're going to see. And this is important because students get confused between how to evaluate if a drug is working, and they get it confused with the adverse effects. So don't get this confused with the adverse effects. If you're asked how to evaluate if the drug is effective, don't say the absence of the adverse effects. Okay, so you'll know it's effective when the urinary output decreases and the urine specific gravity goes up. Because remember, I told you the specific gravity is really low. The sodium is going to return to the normal range. They're not going to be complaining that they're thirsty anymore. And the serum osmolarity is going to return normal, the blood pressure and heart rate as well. Okay, so for pituitary tumor, we talked about this for exam 1. And the treatment is removal of the pituitary, so a hypophysectomy. Anytime somebody has brain tumor, you're going to want to prevent the increase intracranial pressure. You're going to monitor for DI, so greater output than input. They cannot blow their nose. You're going to have the head of bed 30. The head and neck are going to be neutral. No bending, no flexing. They cannot brush their teeth after because it increases intracranial pressure, and they're going to have a mustache stretching. Test any clear drainage for glucose and halo sign. All right, so that does it for the pituitaries. Now we're going to talk about hypo and hyperthyroidism, and this is fun as well. I really enjoy that. Well, I guess I'm going to have to do that. This is stopped. I'm going to do it in another video.